Good morning, Your Excellencies, ladies and gentlemen. Welcome to the TCTAP 2023. And first, I would like to say we are extremely grateful for joining us so early in the morning. And this year as well, we announced the start of today's conference with a live transmission in Asan Medical Center in Seoul. And before that, please allow me to introduce our distinguished specialist on stage. Today, we have Dr. Antonio Colombo, Dr. Gary Mintz, and Seung-Jung Park for the moderation, and Dr. Adrian Banning, Dr. George Dangas, Dr. William Fearon, Dr. David Hildick-Smith, Dr. Duk-Woo Park, Dr. Pieter Smits, Dr. Huay Cheem, Dr. Alan Yeung for discussions. Thank you very much for joining us today. And so I would like to hand off the microphone to the moderator, Professor Park, to moderate this session. Would you please?
Thank you for this opening of the 2023 TCTAP and live cases from the Asan Medical Center Force. And so, okay, ready from the AMC, Dr. Kang.
Good morning, Dr. Park. Yes, I can hear you.
Okay, so we, as you know, we have many, legends here. So distinguished panel, the moderators, Antonio, Gary here. So, you want to start your first case?
Yes. I'd like to introduce my team. So this is Professor Cheol Lee from the Kang University. And then my senior fellow, Hyun Kim, will join our live demonstration. So, Professor Lee, could you introduce our first live demonstration patient?
This patient is 48-year-old male, and he has a history of hypertension and dyslipidemia. He was referred for chest pain. Coronary angiogram shows chronic total occlusion at mid-RCA and diffuse severe stenosis distal left main and proximal mid-LAD bifurcation region. PCI at RCA CTO region was performed 3 years ago. Today, we will treat the left coronary artery. Next. He has hypertension, dyslipidemia, and ischemic heart disease family history. Next. EKG is normal sinus rhythm. Next. Yeah. Chest X-ray show normal lung and no cardiomegaly. Next. Echocardiogram show normal LV systolic function without regional one motion abnormality. Next. This is baseline coronary angiography. Right coronary angiogram shows mid-RCA CTO region. 3 days ago, we performed RCA CTO PCI, and Giants, we put the Giant sky point to 3.5, 48 millimeter, and 2.75, 48 millimeter overlapping. Next. This is left coronary angiogram. Left coronary caudal view, we show the distal left main significant stenosis. And next. Left cranial view, proximal to mid LAD region is significant stenosis with heavy calcification. In spider view, there's distal left main bifurcation region, left main LAD proximal os, and a big, relatively big high diagonal stenosis, and intermediate insignificant stenosis and circumflex ostial region. Syntax score is 39 points. Next. This is our case.
Thank you, Professor Lee. Do you have any comments on the patient history and coronary angiogram? So could you show us that the first coronary angiogram? As Professor Lee mentioned that the RCA already we treated 3 days ago. So this is the spider view of a patient, very calcified, complex left main trifurcation, including the distal left main bifurcation, high diagonal branch, and circumflex. So how to treat this patient?
All right. Anyway, in fact, this kind of main top lesion intervention is our anesthesia, our daily practice, right? However, I would ask from the panels, I'll say total occlusion, bifurcation, truly tough, including the first diagonal arms branch though. So is it good candidate for surgery, Antonio?
Yeah, of course he's a good candidate for surgery, but if you already have opened the right coronary artery, it means that you've decided not to do surgery. So, but you can also do surgery after opening the right coronary artery. You can do 2 arterial graft on the left and the stents on the right, so it's okay. But I think he's also a good candidate for PCI because the vessels are big. The left main can be done with 1 stent. I don't think you need the 2 stents here. So it's not, it's very reasonable to do PCI as well.
I mean, sorry, yeah.
Well, I definitely agree that once you open up the RCA, you have additional vessel open and you directing towards a PCI. The tightest lesion is towards a circumflex. I'm not sure how the territory, how big that territory is from this view. But clearly, I would say that there's a heavily calcific lesion. You may want to employ the possibility of a rotablator here down the both vessels in order to facilitate expansion. I think we saw some of this. The ramus is important as well. You may want to employ some atherotomy there in order to preserve it. I don't think we need to guide towards a stent of the high diagonal, but I find difficult to believe that we're not going to deploy 2 stents.
I just want to comment that for 48 years old, this amount of atherosclerosis is very concerning. So I think you have to make sure that he's not a heterozygous familial hypercholesterolemia person, even though he is a smoker, but this is a lot of disease. So,
especially in a Korean man at this age.
But I think the right way to approach this, though, is not to decide at the start, am I going to put 1 stent in or 2, but to decide as you go. You do it in a professional stepwise manner. Okay, if you need to have a 2nd stent at the end, that's absolutely fine, but you start off, as Antonio suggested, balloon, cutting balloon, IVUS, etc., stent, pot, then a kissing, and then at the end of that, if you do need a 2nd stent, that's absolutely fine, but don't decide before you start it.
Yeah.
I might take a different view on that because by definition, 2 criteria, this is a complex PCI. And this circumflex artery is actually not so easy to negotiate once you put a stent across the left main. So in a complex PCI, I will go straight for a 2-stent strategy, whatever choice you want. And it's actually a lot of work to be done from a PCI standpoint.
I think the circumflex is relatively small and so much diffuse disease. So I think you really have to do all you can to avoid to stent the circumflex. Because if you start stenting the circumflex, you're going to have a full metal jacket on the circumflex. You're going to waste a lot of time for a vessel which is most probably not so important. So just keep it open, do very little on the circumflex.
Dr. Did you hear that? And so
Yes,
what would you do there?
So yes, this is very complex left main, distal left main bifurcation, trifurcation cases with a very calcified lesion. So we'd like to treat this patient like bypass surgery, cabbage-like result. So we try to the very complex PCI procedure today. So even though very calcified the complex lesion, we can modify the calcification using the high pressure balloon and some step by step. So I like to show the complex two-stent technique using the crochet. So what is your idea for the high diagonal branch? Actually, we need some protection of the high diagonal branch using the. So I'd like to show you that the more complex double crochet technique to put the stent in the high diagonal branch, and then circumflex, and then crush, and then cross over to the left main to the LAD. This is my plan. Do you have any idea?
Let's look at some imaging. If you have imaging yet, or Dr. An?
Yeah. I'd like to show you the imaging. Could you show us the circumflex ostium? Yeah. So this is the circumflex pullback.
We're not seeing it.
I don't see it.
There we go.
Good.
No.
So this is circumflex pullback. Because of calcified lesion, virus cannot passing through the distal leaf. This is a very proximal portion of circumflex. And the circumflex is more than around the 3O vessels. This is a small vessel from here. Here is the ostium of circumflex, a very calcified lesion. This is left main. Left main is huge, around the 5O something.
Can they just freeze at the ostium of the circumflex, please?
Yes.
Right there. Stop there.
Yeah. Okay. Stop.
Okay. Now back up, back down. Stop right there. Good. So you got a lot of calcium, but it's not a single arc. So that may actually be fairly easy to dilate. Distal to this, you have a calcified nodule over a fairly long length. But right here, I would not be surprised if this responded either to standard non-compliant or high-pressure balloons, just because this is not a rock of calcium. It's a piece here, a piece here, a piece here, and they can be spread apart.
Yeah, I fully agree with you. But one additional thing we have to consider is the angle of circumflex. The angle of circumflex is so actually reverse angle, so not easy to passing through the device to the circumflex. Anyway,
one other comment, Antonio. I know your preference is to do single stent crossover, but this lumen area and pressure burden is going to make that tough.
But you can make the decision after pre-dilatation. You don't need to be. The problem of the circumflex that there's so much diffuse disease downstream. And, you can leave even if you have a stenotic circumflex. It's not...
Well, I mean, we're going to jail the circumflex, we're going to jail the diagonal. We're jailing a lot of it if you add both of them. That is not, that's a concern. And I think that the ostial circumflex can be treated without messing up with the middle and distal parts of the circumflex. I mean, it can be done separately.
So what are you doing now? Because we just see...
Okay, this is, I already applied high pressure balloon to the circumflex because the iris cannot passing through the circumflex, but fortunately after dilation, after apply the high pressure balloon, iris cannot passing through the distal tight lesion.
So this is the circumflex again?
Yes, the circumflex again.
What size balloon did you use on the circumflex?
2.5 high pressure balloon.
2.5.
So you've got a bit of a dissection and a bit of a hematoma we just passed by.
Yeah, right.
Here's another more of a dissection and a hematoma.
And a hematoma, yeah. Very interesting.
From 3 o'clock to around 7 o'clock. But this is balloon effect. This is what balloons do in calcified lesions.
Well, Gary predicted that the circumflex is going to give
and here
nicely.
you see, again, well dissected.
Yeah.
Big vessel, this is more than 3.
Yeah.
Big vessel.
3O vessel, but 2.5 is...
We still haven't gotten to the ostium. I don't know what else was where the balloon was actually dilated, but this is more of the calcified nodule. And now we're coming up to the ostium. See again more dissections. Okay. We're looking for the LAD guide wire, which tells us that it's the ostium. And this is probably the ostium.
LED. Yeah.
And, you know, it's dilated. You know, you expanded the lumen pretty reasonably with just a balloon.
Yes, please give me the 30 high pressure balloon, please. Yeah. So the facilitated device passing through the circumflex, I like to do more lesion-free modification using the high pressure balloon 30.
Sorry, do we
So
IVUS for LED?
I already put the one stent to the LED because this with the LED show that some stenocysts. In addition, because of a calcified lesion, device delivery is not easy. So I inserted a 2.5 balloon to the LED. I use this balloon as an anchor.
You deploy the one stand for the distal LED, right?
Yes, right.
Okay, would you show us IVUS findings LED?
No, not
yet, right?
Not yet.
Yes, not yet. After high pressure, I will show you the. Okay. High pressure balloon easily passing through the circumflex. Test, please. Okay, here is my distal landing for circumflex 10,
Circle 10, 10,
12, 13, 14.
14.
Deflation.
Deflation.
Balloon is well dilated. 16.
16.
What size balloon is this?
30 high pressure balloon.
What size? 3
20. Yeah, 30 or 20.
balloon.
16,
16.
18, 20,
20.
24.
24.
Yes, look at can you see the full dilatation of a balloon, no indentation, so well dilated, heavily calcified, but the calcification is well modified by the high pressure balloon. 16.
16.
Deflation. Okay. Please give me the IVUS, please. Always, I'm doing my procedure with intravascular ultrasound. So the most important thing is doing intravascular ultrasound for the complex PCI. Another second important thing is I think the operators have to interpret the imaging itself, and then if there is something wrong, we have to apply something more to correct the
I'm sorry?
suboptimal lesion.
There's a stent in the LED.
He put one in already.
Oh, he put one in
Yeah.
already? Okay.
Yeah.
I missed
Anyway,
that somehow.
Anyway, this is the stent with the LED I already implanted. So this is just above the stent. LED vessel size is also not so small. Vessel size is around the 4O.
Encircling calcium.
Yeah,
Again,
encircling
this
very
is,
calcified lesion.
although it's circumferential, it's not solid, which means that if you have breaks in the calcium, you can spread them apart.
Yeah.
Size-wise, almost 4 more than the other.
Yeah.
Big artery with a large
A lot of
plaque.
plaque burden, yeah.
High diagonal range
That's the
coming from
By
the
the
2
way,
o'clock.
you either see a dissection or a plaque rupture at 9 o'clock.
So plaque rupture, you can see it beforehand in the
Well,
previous
there was a suggestion of it angiographically. So I think there's a plaque rupture at the ostium of the LAD.
Very close to first diagonal and circumflex ostium.
Yes,
So Dr.
right.
Ahn, you want to plan to do the 2 stand for diagonal branches though?
Yes, I would like to stand for the diagonal branch. But before IVUS evaluation,
Can we replay the IVUS just for the audience
Yeah.
once more quickly?
IVUS run, please.
Again, so this is the freshly placed stent. At this point, it's well expanded. we want to see, you obviously want to do measurements. You look at the edge looks okay. You see a lot of calcium, but it's not a solid 360 of calcium, even though it may add up to it. There are multiple arcs that overlap, so they can be spread apart. And then, but it's got a lot of length to it. The vessel size is big, there's length, there's no calcified nodule, there's no 360 calcium. This will dilate fairly easily. Come back to the IVUS, please. Back to the IVUS, please. No.
I was.
Never mind.
Okay.
Never. Go a little more distal, please.
Distal, more distal. You mean the distal LAD?
Right there. Stop. Just let it play.
Stop. Yeah, play. Play.
Thank you.
Yeah.
So it's a big
High
vessel.
pressure.
And big vessels are easier to deal with than small vessels because of Laplace's law. You see some deep calcium. Now you're seeing at 9 o'clock this flow into the plaque, which probably represents a plaque rupture. My guess it's an old plaque rupture, but that's just a guess. Now we're into the distal left main, because you see the circumflex wire coming in at 1 o'clock, and it's a huge left main. It's a 1, 2, 3, 4, 5. We'll get close to 6. Okay.
18. 20.
Anyways, for the main interventions, we almost routinely used IVUS, imaging guided, where the calcium.
What size balloon is this?
This is 2.5 for high diagonal branch.
2.5.
Yes, because high diagonal branch is not that big. And then after high pressure for the diagonal branch, I'd like to show you that the high diagonal branch vessel. So IVUS, please. Even though very calcified lesion, when we apply the high pressure balloon, then we can modify it easily. But if a high pressure balloon fails to dilate it appropriately, then we need the more aggressive calcium modification device like lotabulation. But fortunately,
can you see an angiogram at some point?
Yeah.
No, we don't do angiography, Antonio.
You don't do
Okay. Okay. This is the high diagonal branch. High diagonal branch is 2025 something. Vessel size is 2025. Here.
More than 2.5.
Yeah, more than 2.5.
But at least the distal vessel looked fairly healthy, which was seems unusual for him to have any parts of his vessel that are that look normal. Here's a big dissection from 4 o'clock around to 9, 10 o'clock. Small calcified nodule. He's young for these calcified nodules.
So sometimes the big dissection means the means the well modification of calcification. So sometimes it's a good sign for intervention.
I'm just going to ask, does he have renal insufficiency at all?
No, kidney is very, kidney
I-
function is very nice.
Not yet.
Yeah.
No, because you're looking at somebody who's 48 with this degree of calcific atherosclerosis. You sort of wonder why. I mean, I think Alan's point is well taken, but there are other things that could be contributory.
For all high pressure balloon. So I'd like to insert the stent to the high diagonal branch and the circumflex first. Insert the balloon to the LAD. LAD balloon can be used as an anchor to deliver when we deliver the device to the high diagonal branch and circumflex.
Dr. Do you use a French guiders?
Yes, a French guiders
For
and
the
then
complex
okay.
procedures,
Yeah.
the stills, we use the larger size guiders. A French, two,
yeah.
two stands, sometimes we.
So could you give me the stand? So I'd like to stand to the.
Do we need to do a little bit of lesion preparations for the
Yeah.
LED? You know, that focal spot of concentric calcifications.
This is a 4O.
He's trying to
What
dilate.
size
pressure
balloon
balloon.
is this?
40.
4
This is a
millimeters.
4O. Yeah, 4O.
But, you know, I think in a young man like this, you have to limit stenting. You cannot place 3 stents in a 48-year-old. Yeah.
Deflation.
I think
Right
this
up,
is...
please.
Well, what's the downside of placing additional stents in a 48-year-old? The outcome is if they don't fail, he has a good target. He's going to get a quadruple
the
target.
outcome is that you will have events on in 10 years. This stents is going to be wrist and nose for sure.
So, for sure.
Well, it's
We don't know
If you
actually.
continue his
the-
course, it's not the last
The
10 years.
circumflex, I guarantee, is going to wrist and nose. I guarantee.
Actually, based on our data, 5-year event rate, if you apply the high pressure balloon and achieve the very good stent, minimal stent area for circumflex ostium, then the 5-year event rate is very low. 5-year only 5% or 6% event rate, including the repeat intervention.
Yeah, but the fact that you have no events doesn't mean that doesn't wrist and nose. So if you do nothing, you're not going to have no events. The same.
Well, I mean, this vessel is also a good idea for multi-vessel lithotripsy that we discussed quite a bit yesterday in the side sessions of
Circumflex
first day of TCTAP.
Circumflex 3O.
Stent.
Oh, stent.
All right.
Yeah. So,
So, Jung-Min, you're going to stent the diagonal and you're going to stent the
yeah,
circumflex
right.
and then
Yeah.
close
I'm
those
gonna-
and then...
But this is the
Yeah, I wanna
moment,
put
isn't it? This
with-
is the decision point, because actually you've got good balloon dilatation
Yeah.
to the other two vessels.
Yeah.
It would still be possible to do a provisional approach, left main to LAD, and leave the balloon result in the other two vessels. But as soon as the next stent goes in, there's a lot more stent going in.
I think, though, given the sections that are there, you're committed to the multi-stent up front now.
Well,
yeah.
yeah,
I'm not
flow
sure
is
that's
good,
true.
you know.
I'm not sure that's true. I mean, for example, if you were to believe the data coming on drug-eluting balloons, then you can leave a dissection that's not causing staining. And I must say, I rather agree with Antonio that, yes, I don't doubt we're going to get an angiographically beautiful immediate result here with dual stenting in the diagonal and LAD and dual stenting of the left main into the circumflex. It's going to look beautiful at the end of the procedure, but that's not really the point, is it? The point is what happens to the patient in 2, 3, 5 years' time.
Well, I mean, this patient is relatively young. If the stent restenosis, one stent restenosis or multiple stent restenosis, there's a bypass option with good distal targets is always there. So, you know, it's a different thing to say that an older patient, then I'm more motivated to leave things behind because, you know, that...
Sure, but once you put a stent in, you can't take it out.
Yeah,
Why do we need to take it out? Stent or no stent, we can always bypass distally. The stent doesn't do any harm here.
Surely we're not setting out to do a bypass operation.
Well, in 10 years from now, he may have one.
I mean, he's only 48, so, you know,
But
I don't
at
think
this
will last.
point, why don't you do it now as if you were thinking about bypass?
I'm not thinking about bypass, but it's a backup option.
You want to waste resources to do
Is it-
PCI, you do bypass.
Is it 2.5 stent, Dr. An?
No. Yeah, excuse me?
2.5 stent, 2.5?
Yeah, 2.5 stent.
Okay.
So I like to additional high pressure balloon 2.5 to optimize the side branch ostium because
The diagonal branch is a good vessel for DCB.
How long is the diagonal stent, Jung-Min?
28.
Okay.
28 to 5, 28.
Because
Are you gonna post-dilate? You're gonna post-dilate it as well.
He's
Yeah.
going to post-dilate now.
And what you're going to do on the circumflex?
He's going to stent it.
That's the next stent.
16,
Another
18,
stent.
20.
We're going to place 3 stents.
Yeah.
4 stents, because there's one in the LED already, so...
This is old-fashioned PCI.
Yeah, I was about to say, isn't this what you did, Antonio, in the early 1990s?
Yeah, that's what I did. This is old-fashioned.
It's not old-fashioned, it's classic. It's classic.
Younger than you are.
It's an all-time classic. That's what it is.
This is classic.
All-time classic.
16.
But I
I
think
remember
getting a,
TCT when you did a trifurcation.
Oh, yeah, of course.
I think at this point in time, what we want to do is to
But
get
you
the
know,
best
it's,
geographic results
Just
possible.
move. You
I
make a
crossed the
change.
LAD diagonal using high pressure balloon 4O. So circumflex stand. Ready? Yeah. Ready?
I mean, the interesting thing is that we don't have any classic approach plus PCSK9. You know, in this situation, it lowers cholesterol to nothing.
What are you doing circumflex?
By the way, I'm still not very happy with the expansion of
I like
the
the
Ramus
insert
stent.
stent.
I think we have to do more post-dilation with a higher balloon in Ramus.
Yeah, also the ostium of the circumflex is not very good. I will do cutting balloon on the ostium of the circumflex.
Yeah, I would advise a higher, bigger high-pressure balloon in the Ramus and the circumflex.
Yeah.
LAD 10.
That may be the effect of the crush, I think.
But to prepare these lesions well, you need if you have a 8 French guide, you can do a
Yes.
balloon inflation, 3 balloon inflation.
Deflation.
No. Balloon should be more,
Yeah, distally.
inside in terms of LAD.
Okay,
Right, good,
10.
perfect. And then impact guide force, great. Wire pushing.
No. LAD deflation. Take out the diagonal wire. And LAD 10.
Oh, yeah.
There's a strut there.
Deflation to 5. To 5 compliant balloon. We need more the lesion modification because diagonal circumflex ostium show that very calcified and the reverse angled. The delivery of a device may be difficult due to the aggressive calcified lesion.
Sorry, is this a crush technique we're doing here? Was there so the
10.
stent is into the LAD, or is just meant to be precisely at the ostium?
I
Precisely at the ostium.
Yeah. Depletion. You 1 to 5. Compliant balloon, please.
You did.
The strut is
Trouble with kneeling the ostium, you always have 2 problems. Either you have an osteomes or you have a main vessel protrusion. And sometimes you have to
I mean, in order to avoid this situation and taking advantage of the 8 French guide, the circumflex stent and the Ramus stent could have been placed at the same time.
Yeah, good. Yes, that is a good idea, but LAD 10.
Yeah, the position of the Ramus stent may impact on circumflex access now.
Yeah.
And that's going to be the
Deflation.
challenge.
Yeah.
I mean, the way the balloon's
1-5.
behaving, it's not just the ostium circumflex
1-5.
disease. There's something in the way, and it's probably metal.
The strut of the stent.
Yeah.
Okay, Dr.
And these trifurcations are all about
Yeah.
sequencing, aren't they?
1-5.
Actually, you take care. We're
Yes.
going to move on next room, and we
Okay,
will
thank
be
you.
back for Dr.
I'm going.
Kang.
Yeah.
Next
hear
room,
you.
please. Okay.
All right, great.
Can you hear me?
Yes, I can hear you.
All right. Do-Yoon Kang is junior. So, all right. Would you
Yes. Good morning.
introduce your case first?
Yes, this is my honor to present the case in front of the masters of the PCI. I will introduce my team. I am Dr. Do-Yoon Kang, and the junior staff in the Asan Medical Center. And he's the professor at the Sangwoo Park of the Ulsan University Hospital, and Jin-Ho Lee, our senior fellow. And we prepare the case of the bifurcation case. And Dr. Lee, can you please present the case?
Thanks for introducing me. Hi, I'm Jin-Ho Lee from Asan Medical Center, and let's start a brief summary of this case. A 45-year-old male patient was admitted for stable angina.
Not making me very happy
And
here.
coronary angiography showed a significant stenosis at distal and main, 2 proximal LAD, and mid LAD with the diagonal branch bifurcation lesion. So we planned the revascularization of this lesion. He had no past medical history associated with the coronary vascular disease. Next. And he has 3 demographic characteristics of risk factor, the hypertension and hyperlipidemia, and familial history of his brother have a coronary artery disease at age under 45. In this patient, clinical presentation is stable angina. Next. Electrocardiogram show basically normal sinus rhythm with no ST change. Next. In chest radiograph, they show no pulmonary edema and no cardiomegaly. Next. And we checked the non-invasive study. The echocardiography showed normal LV systolic function without wall motion abnormality. And let's see check the coronary angiography. Next. In the RCA, distal RCA have the mild stenosis and some collateral vessel from the big PDA from 2 distal LAD, the epicardial channel. Next. In the left coronary angiogram show in caudal view and mild stenosis of circumflex and rim branch. And we see the cranial view at the very tight lesion in mid LAD and diagonal bifurcation lesion. Next. The area cranial view showed a very severe angle of the bifurcation lesion. And at the spider, we checked the distal LAD disease and significant stenosis at proximal LAD. Next. So we set the target of the main and LAD and diagonal bifurcation, and we prepare the IBUS for intravascular imaging. We adjunctive medication, aspirin, and clopidogrel, and beta blocker and statin.
The summary, the patient, another young guy with a stable angina, and skipped in the history, the CT, because the patient visited the outpatient clinic because of the stable angina, and we checked the CT, coronary CT showed severe stenosis and the LAD. And the patient went into the coronary cath lab, and the coronary angio showed severe stenosis of the LAD. And distal LAD, there's epicardial collateral. We cannot see the very distal in the angio. Maybe it's a competition, I think.
Okay.
And yeah.
All right, Dr. Kang, you want to discuss something? All right, this angiographic findings just clearly show the bifurcation LAD and diagonal branches, and proximal LAD, there are some disease over there, right?
Yes.
However, the significant concern is we have to see that after. So, what did you do there, Antonio?
But I would.
45.
I make this decision after the result following predilatation. I would predilate LAD and diagonal. LAD most probably 3.0, maybe even 3.5. Maybe I'll do IVUS after predilatation. The IVUS may not cross now. Diagonal I will predilate with a 2.5, kissing balloon during predilatation. And then I'll make the decision. I will try not to stent the diagonal and most probably use a relatively short stent and not cover the ostium of the LAD because it doesn't look so critical, and use a short stent only for...
Okay, you don't want to touch proximal LAD part.
I don't want to touch the proximal
all right, and
LAD.
if possible, so you want to stent for the diagonal branch.
A short stent and the
right?
DCB on the ostium of the diagonal.
Alan, any other options?
No, I think I like to see the imaging. I think that helps a lot to decide what to do. So,
and I'm not so sure that there's left main disease.
Yeah,
I think the ostium of the LAD looks really suspicious here.
Yeah. Of course, the ostium. If you do IVUS, the ostium is going to be, but it's okay. I mean,
I think the biggest challenge here is actually to wire the diagonal.
Yes, I agree. The wiring is going to be tough.
Yeah. So you will take some techniques here to go into the diagonal.
Georgie, Dangas, what did you do there?
Well, I think I agree that the main aspect is the LAD diagonal. We have to do imaging to understand better the proximal LAD. If it ends up being significant, we may have to put a very long stent from the mid LAD all the way to the left main.
Any other?
Yeah, I think
Fearon?
I mean, the other option would be to do as Antonio said and then do an FFR or IFR of the proximal LAD.
All right, great. After the stand for the down.
Yeah.
After
Yeah.
the end, yeah.
Great, great. Oh, that is our plan. All right, from the beginning. Anyway, issue is upfront two stand for the diagonal branches, or just you mentioned kissing balloon first, and
Yeah,
then
I will do
then
kissing
what's
balloon at the beginning and then decide, but,
All right.
you know, the diagonal, you can, it's a short lesion on the diagonal, you can...
Dr. Kang, how would you do that?
Yes. Thank you for the discussion. I planned to the upfront two stand for the diagonal protection. However, I will see the balloon first and see the result, and we can discuss again maybe. And I will show you that I did something waiting for Dr. An next. And as the panels discussed, this is not LAD disease. This is not left main disease, LAD ostial disease, and minus please.
So, would you?
Minus. Wiring to LAD was easy, and the wiring to diagonal was a little bit difficult. So I used the double lumen catheter and the BMW wire with the shaping of the tip of the wire, and fortunately it passed through the diagonal without many faults. Yeah, not easy, but not very difficult.
I wonder if you needed the special catheters with a 90-degree angulation to wire this diagonal.
Yeah, in some very difficult case, I used that or perform the knuckle wiring, but unfortunately, I could pass through the diagonal branch. And next, and after wiring into the LAD and diagonal, we did the imaging for the LAD and diagonal. Can you please show me the IVUS?
Okay, IVUS.
Yeah, LAD pullback, please. This is the LAD pullback from the mid LAD. The vessel size at the mid LAD normal region is 3.0, and there's some mild plaque. And just distal to the LAD at the diagonal branch, there's another normal zone.
3.0 vessel.
Yeah, about 3.2.0, yeah. And the plaque begins, and not very heavily calcified here. And you can see centric calcium, and diagonal branch comes from the 9 o'clock and septal from 3 o'clock. And here is the tightest region. This is pre-balloon image. I did not perform balloon.
Septum.
And this is the prox LAD region. And to LAD osteo, the plaque is more prominent. And this is the osteo. And I also checked the diagonal. This is the second run. This is diagonal run before ballooning. I could pass the
2.5 diagonal branches.
And you can see a short, tight region at diagonal osteo. And can you please show the angio again?
Could you just show the very beginning of the LAD IVUS? Just the very beginning. I want to point something out to the audience.
First run, IVUS first
LAD
run.
IVUS.
Can you please show? First IVUS, LAD IVUS at the first beginning. Yes, thank you.
Okay, now stop right there.
Stop.
Stop and go back.
More distal.
Go back,
More
go back,
distal.
back.
Yeah.
Okay, you see at 12 o'clock, you see that black thing? That's probably some intima lifted up by wire, maybe with a little bit of thrombus. Not that it's going to impact anything, but you sometimes see this if, when there's a wire crossing.
Wow.
But there's a clear small dissection from 12 o'clock to around 2 o'clock.
Yep. Very interesting.
Go ahead.
Yes, and we check the length of the total length. If I cover from the mid LAD to prox LAD osteo, full length is 48. And if I cover can you please show the angio, RAO, please? From the just distal to the diagonal to LAD osteo. Actually, I want to cover the LAD osteo because I can cover full region with just one stent. So I just lengthen a little bit more and will cover the prox LAD region. and that would be 34. So actually, I planned to cover all region with just one stent. Because we have long stent, I can cover all region with the one stent.
Regions, right. You want to cover the whole region, right?
Yeah.
Proximal, up to the proximal LAD though.
With LAD.
How long the...
If I cover all, it's 48. And if I do not cover with LAD, it's 34.
48.
We can
Depending
cover
on
with
one
one
artist
stent.
measurement. 48 millimeter long stent, is it okay?
Yeah.
For your practice? Oh, right.
I mean, in this case, I agree with it.
Lengthwise 50, and I would say effective stent area at least 5. Do you agree with that one? No.
The key thing is to make sure that the vessel stent is tapered to the natural anatomy. That you don't try and produce a tube which is the same diameter at the ostium as it is at the distal end. So we size the distal vessel, we cover it all, and then we inflate it sequentially to match what size the vessel should be, to match the natural size of the vessel. And for me, this is still a provisional case. I think there's a good chance we could get away with one long stent in the LAD and a provisional approach in what is an important diagonal.
All right, maximal opposition of a stent is important. However, I'd really like 5 millimeter squared in a stent area. In any situation, if the vessel diameter is more than 2.5, we can achieve 5, at least 5 millimeter square. So 5, we're going to make a good result and good clinical outcomes also. All right, Dr. Kang, go ahead.
So are we going to pre-dilate the diagonal at all?
Yes,
or
I dilated the diagonal.
just to keep the vessel open?
With a 2.5 balloon. Next. Next.
You're gonna land the stent in the ostium of the LAD or in the left main?
I want to put the stent in the ostium of the LAD.
Okay, you're gonna have a significant pinching of the circumflex.
Yeah.
That's
maybe not.
Is
and this is the result after ballooning of the 2.5.
We'll see. I think I like to see the result, but the circumflex is going to be pinched pretty heavily.
Looks angiographically as though it's going to be hard to land it at the ostium of the LAD. I'd have thought you're coming back into the left main.
I actually think there's room in the ostium of the LAD.
Well, there is room, but there's a lot of overlap also, so I don't know how well they can police that.
Well,
need a spider view here.
Spider view actually is pretty good, George.
Spider view, please.
Perhaps they can put the wire of the diagonal into the circle, that might help.
There's some disease or proximal LAD.
Yeah, I don't think you can land that at the ostium of the LAD.
The IVIS shows that this extends into the left main a little bit, right? So from proximal LAD.
Yep.
Yeah, go ahead.
Yes. And after ballooning to the diagonal branch or the 2.5 wire.
What if you just stent the LAD where there is a bifurcation and then you do an FFR? What is the what is the rationale to stent the ostium of the LAD if it's not critical?
Yeah, and if you're going to stent the ostium, it looks like the mid to distal LAD could be stented too. I mean, there's disease extending all the way down there.
I mean, are we stenting to treat atherosclerosis or to treat ischemia?
Either.
Well, I don't know.
Anatomic, you mean the ischemia?
There's no any data that stenting is used to treat atherosclerosis.
Sometimes we cannot discriminate in terms of small discrepancy, anatomic and ischemic concern, and so I think if 48 long stent would be okay, why not? We're going to do the,
But if it's not critical, now we have a very good medical therapy for lesions.
But I have a concern of the not covering the proximal region because we are doing the procedure and many balloons and catheters and wires going through and make some damage, and I concerned about the progression of the proximal region. For distal, I am okay with just putting the stent that does not stent the distal region and put the stent here with a shorter one. But proximal region, I have some concern of that the disease progression after the mid region procedure. And this is the after ballooning with the 2.5, and you can see the opening of the diagonal branch. And this is after pre-balloon. The proximal, here is where Professor Colombo said, put the stent there, or cover this proximal region also.
It's proximal.
Yeah, here is the opening.
It's the main, right?
It looks like there's osteo involvement here. The challenge here is that the angle between the LED and the circuit is actually quite acute.
Yep.
And so there's a risk of compromising the lumen of the circumflex with coronal shift and so forth. So I think going to the left main might be the way to go, but you need to choose a stand where you can expand all the way up in the left main with its expansile characteristics.
But I think it is different, isn't it? The ostial and proximal LED has been touched with balloons and intervened upon, so I would cover that. I'm not sure I would leave that now in a young guy like this. I think if we're going to put a stent in, let's cover all that disease segment in the LED.
Yeah.
So what is next, Dr. Kang?
And I also checked the diagonal.
You did just the
for your concern. Yes, this is diagonal run after ballooning. Can you please show the angio? The left angio? Yeah, perfect. After 2.5 ballooning, I can see the same finding as the angio. You can see the dissection of the diagonal branch in the osteo. And with this imaging finding, actually, I'm not so brave just to cross over this region or just to treat the DEB. I decided to perform the two-stent for the protection of the diagonal branch. 2.5 and
I thought the diagonal ostium looks pretty tight before you dilated. It looks pretty tight on IVUS, as well as that 90-degree angle is going to be.
I wonder if we need to do a cutting balloon or something in the diagonal ostium.
I think he dilated it already.
It's a big diagonal. We need to really have a very good result there when we go this very long stent, because after the stent we're mostly focused on the ostium, and I think we should secure the diagonal a bit better.
Well, he has pre-dilated the diagonal, so there's quite a bit of dissections going on.
Yeah.
But the flow is pretty good, actually. I might just leave it alone.
I mean, the angle of the diagonal is a little tricky too, right? Because once you have a wire in, it changes the configuration a little bit, so it's hard to evaluate.
we need further dilation, 2.5 NC, please. Yes, as the panel said, so we need further.
Interesting. We had a lot of shift towards the diagonal. The equipment did not deliver, so it does need a better preparation there.
This is 2.5 NC. I will apply NC balloon to diagonal ostium to further dilate. So there's because of the angle, there's severe resistance here. Okay. 12, 40, 60. 18, 20, 22, inflation. Okay. One more time, 20, 22, 24.
Yeah. Let's see, hopefully things will deliver now.
And LED balloon, please. 3.0 balloon. Yeah. I will use the crush technique, not only because Professor Colombo is there, but I love crush technique because it can secure the main branch during the whole procedure, and we can keep safety during the procedure. Okay, this is the balloon for LED. Because there is some resistance to cross the diagonal branch, I will insert the LED balloon first and use as an anchor if needed. This is 2.5 stent again.
Well, it's mostly an alignment situation because of the angulation. So hopefully after this high pressure balloon, I don't know, we'll need the anchor, but it's good to have it.
Okay, I'll try.
I wonder if it makes the guide, the equipment too tight into the guide, because you already have a balloon in and you're trying to deliver a stent.
Oh, it's deep support.
I still have the difficulty in crossing the stent.
You see how much work you do for
nominal 3.0.
You may want to, if it doesn't go again, you may want to select a shorter stent.
Yeah, I agree.
But maybe you
No
don't
stent.
need a stent. Maybe you don't need a stent.
Or you do a cutting balloon or an angiosculpt.
Why do you have to stent the diagonal? There is an occlusive dissection. What's wrong? Not to stent the
3.0
diagonal. Please,
14, 16. Ratio.
To be fair, I think most of the data would support in this setting that so long as the diagonal remains patent, you have a good result, and the patient does.
you can do a DCB on the diagonal and that's it, and you are done.
3.0 nominal.
Any stent on the diagonal will restenoze. Any stent.
Difficulty.
Yeah, we have a problem delivering there, so this means some undilated ostial area, so a better preparation there would be good. Whether you leave it after that or not is up to you. It's optional, the stenting. Yep.
Yes, I agree.
The only way to prevent restenosis is not to be able to deliver the stent.
You know, the only evidence for DEB in a bifurcation lesion is in the PET-CAP bifurc trial, and in that trial, it only shows an improvement in terms of late luminal loss. We don't know, there was no clinical difference, you know, it was just a small sample. So you perhaps get a little bit of a greater luminal gain with DEB, but otherwise, you know, there's not much of a clinical benefit.
Sure, and I guess that's largely because even a vessel like this is only just about capable of producing angina.
Wow, look how easy the balloons deliver, but the stent doesn't deliver. Interesting.
I wonder if it's, you know, sometimes when we're wiring bifurcations, we won't wire the main branch first because it changes the angle. I wonder if having the balloon in the LAD is changing the angle so much.
And then,
I mean, the other option is to deliver a guide extension catheter over this balloon, and then, you know, you achieve your goal to stent the diagonal.
I can feel some resistance
But
here.
it is a law of diminishing returns now, isn't it? You know, once you're having to work quite so hard for the diagonal, really, it would be more sensible perhaps to leave it with the balloon result.
Dr. Kang is really, you know, is not a kinking wiring
Why
problem.
can we see an angiogram of the diagonal? Let's see how.
All right, just the diagonal stent first.
Yeah,
And
no
before then, another balloon. And just stent.
Stent alone, yeah.
Yeah, just pass the stent alone.
Diagonal first. And really more strong impact of guiders inside. Why not? We're going to try that first. Good. Too much. Anyway,
Yeah, not too
try
much.
that one.
We need more
Okay,
power.
push in.
Yes.
Why not? Slowly.
What is that? Yeah. Listen.
Way in. Okay, good.
Proximal vessel.
All right, well, we have the options of A, shorter stent, 2, guideliner, or 3, no stent.
I go for the third one.
Why we
Bigger
cannot
angiogram.
see an angiogram and see how he looks at this diagonal?
I agree.
Shorter stent, please. Yeah.
I mean, one of the other options at this stage, if you were determined to put a stent in there, is actually to be brave enough to pull your LAD wire back, because there may be some wrap issues that's preventing delivery.
What would you do then, right?
Totally.
Okay.
There's so much overlap in the
Dr.
angiogram
Kang,
that it's just
Yeah.
difficult
You're
to...
using the corset or something as a, what about the change a little bit stiffer wires into for the diagonal branches and rearrange of a guide wire
Yes.
and also a little bit stiffer wire use may be helpful for something?
The LED will be fine if you take that wire out, won't it? So just take the LED wire out to deliver your stent. Yeah. Change the geography. It's an alignment issue, isn't it? It's
Okay, maybe the resistance is from the severe calcification at the bifurcation, and we could see it in the IBUS, and also I can feel the resistance. And because this wire is BMW, and I think that it's not enough stiff to endure the angle. So I will change the wire more stiffer one, and we'll try it again.
Okay.
It's because of the angulation, I think.
Okay, we will be back, Dr. Kang. We want to give you 10 minutes. All right.
Yeah.
Dr. please.
So while Dr. Kang is doing his nice job, I have some.
All right.
I did something. So could you show us that?
Could you pass the one?
Pass
Pass the stand for the circumflex.
Circumflex, yeah.
Would you start that one?
Next. Yeah. So. Next.
Could we see the
Next. Okay. No, circumflex.
All right, circumflex.
Yeah.
How would you?
Please, yes. So actually, I concerned that some overlap the diagonal branch to the circumflex ostium, but the area of caudal view there is no overlap. The difficulty to passing delivering the circumflex stent would be the calcified lesion related with the calcification and reverse angle. So I applied more high pressure to the circumflex ostium using the 3O high pressure balloon. And next.
What?
Next. Run, please. So the
Extended the circulating.
Yeah.
What's happening?
Next. After high pressure, next. After using the anchor balloon to the LAD, the device, I successful to pass the device to the circumflex. Next. This is 3O Giants 33 stand. Next.
3033. Yeah.
Yeah. Next. And I also applied the high pressure balloon 3O high pressure to the full optimization of side branch ostium. Next. And then next. Crushed using the 4O high pressure balloon to the left main. Next. So I removed the old device to the circumflex. Next. Before circumflex wiring and high diagonal wiring, I like to do optimization of LAD stand. LAD stand optimization is very important to facilitate the side branch rewiring and balloon delivery. Next.
Great.
So next. Yeah, after the stand, next. This is 4038. Next. This is the high pressure balloon. Next. Using the daughter catheters, for the balloon is not easy to deliver to the distal stent edge. So using the daughter catheters, I successful to deliver the high pressure balloon 3O high pressure. Next. High pressure balloon 3O distal part. Next. This is 4.5 high pressure balloon to the prox LAD to the left main. Next. And then after I insert the circumflex wire like this, ready. And I try to insert another wire to the high diagonal branch. So test, please. Test. Okay. I hope that easy to insert the wire to the high diagonal branch. Sometimes easy, but sometimes not that easy.
Not sure it's so necessary at this point, but you have achieved already an amazing result.
There is a lot of disease distal in the circumflex.
Yes,
There
right.
is
So
no, you know,
after
jeopardy
stenting
area,
for the left
so,
vein,
just medical treatment maybe enough for that one.
So not just kissing balloons
Ready?
to all of them.
Great.
okay. My wire, all my wire is successfully delivered to the appropriate position. 1.5 balloon, please. So using the small compliant balloon. 1.5. LED.
Finally, two-stand crusher, right?
Yes, two-stand crush. This is 1.5 balloon.
Yep.
LED 4O, high pressure, please.
You could part
Yeah.
them.
For the anchoring.
Yes.
Maybe there is some difficulty to maybe 2 layer of stand over some part of 3 layers something. Yeah, how
Well, I mean, anyone. I mean, I think we can call this procedure very successful and do double vessel intravascular ultrasound down the LAD and the circumflex, and not worry too much about this part. I think.
No, he's trying to finish off with a kissing of the stalagmite.
Yes.
I mean, I
Kissing
think
is
once
very
you've,
important for
Let go.
the two-stand technique.
yeah, once you've put the stent in the diagonal, you have to follow up by recrossing and kissing.
Well,
86.
I would have done this procedure totally different. I would have used one stent from the left main to the LAD, I mean 2 stents because there is another lesion distally, and intermediate and circumflex drug-coated balloons. Drug-coated balloon on the intermediate and circumflex, and the stent from the left main. That's a,
one stand crossover.
yeah, and 2 drug-coated balloons. This is, to me, a more modern way to deal with bifurcations.
Circulation. Okay, 2.5 high pressure balloon.
This triple stent is going to restenosis for sure, for sure. The only way to prevent restenosis is not to do follow-up angiogram.
we didn't do follow-up angiogram.
Yeah, that's
I don't want to see
the
this.
best way to prevent restenosis.
Never look again.
Very effective.
All right. How do you define, Antonio, the small vessel size-wise?
But less than 3 millimeter.
3?
Yeah, less than 3.
LED 6.
3?
Less than 3
Yeah, less than
millimeter.
3. 3 is just a big one. Small vessels.
Yeah, less than 3 millimeter.
3.0.
Any vessel that you dilate with a 2.5 balloon.
일단 1.5.
David, what do you think? Small vessel.
Small?
3?
2.5. 2.5 or less.
2.5.
2.5. Any vessel that you dilate with a 2.5 balloon.
You still. So what I'm talking is in a relatively small vessel. The big one, I really too much concern about even in the DB may work for the reason why it's a big vessel itself. And so relatively small one, so less than 3 or something. Is there any data in terms of?
There is a basket.
The meaning is a drug-eluting stand versus a drug-eluting, balloon. Is there any data for?
No, there is no, because it's something relatively new, so we need to wait another 2 or 3 years to get data. But in the small vessel without a stent, there is a basket trial. It's a lot of data.
All right.
There is a Piccoletto. Now it's been published Piccoletto too.
We didn't see that. Dr. How would you pass the balloon?
Yeah, simply using the anchor to the LAD anchor using the high balloon, and then so another 3.5, 3.0 Yeah.
I think this phase is very important, having put all these stents in, to make sure that you've put them in properly and to make sure the ostium, particularly if that intermediate, is properly open. I think this is a really important phase, not to stop and say, it's done. To spend some time now really making sure that you've expanded these stents the best you can.
Yes, right.
I mean, once you committed to 3, you really need to make sure that they are all open well, kissing them well, and IVIS them. That's when you sort of invest your time and effort to really.
Well, it's the learning from the CTO, isn't it? Is that obviously it's important to get across, but finishing it up right is so important. It's a great case.
It is a great case. And they're doing really, really well. I must say I agree with Antonio, though. I would have tried to limit the amount of stent you end up with, because it does incur a penalty to the patient forevermore.
Yeah, the intermediate could have been treated with a DCB easily in this case. We're gonna, no matter how you cut it, we're gonna end up with a somewhat compressed ostium of that stent.
You know, George, if you do FFR on the circumflex with a lot of diffuse disease that you have distally, it's going to be positive anyway.
Yeah.
Okay.
So, I mean,
circumflex.
To place a stent proximally with a lot of disease distally, I don't know what.
10, 12, so this is a high pressure balloon for CERT. 16. 18, 30 high pressure balloon, 20, 24,
balloons, right?
deflation,
triple kissing.
Nice.
In fact,
this is diagonal.
Antonio, almost 15 years ago, you taught us just high pressure,
10.
Yeah, but
crossing of two stents for the
12.
Progress means changing.
18.
However, we need more data, right?
Yeah, but before building data, you have to build the procedure. And then you build data.
I would for sure go 20 atmospheres in the Ramus balloon right now before the triple kiss. I'm not.
20, 24. 24 high pressure,
I mean,
24
if you do
for
this
circumflex.
triple stenting, we always used to finish with
High
the
diagonal
triple
range,
balloon
18.
inflation. Triple balloon inflation.
It's okay?
18,
Yeah, triple balloon
20,
inflation.
24.
Especially if you have an 8 French guy.
Deflation.
Triple balloon inflation.
Triple balloon
So-
inflation.
It's not an old one, right?
Yeah, that's fine.
So,
Even if you do
8,
DCB,
8.
triple balloon inflation.
All right. 8. So, in fact, based on our data, upfront 2 stent for LED diagonals, any epicardial artery branches, upfront 2 stent, including the main upfront stent, is very good. The main focus is effective stent areas. After the, any kind of 2 stent technique, whatever you use, finally, effective stent area is more than 5 at least. It's good, perfect. That is our data. We got, So, all right, a little bit supportive, conservative treatment. DEB, maybe in the future is another, field of a side branch field. Okay.
This was a perfect result.
Almost done.
Perfect
so
result.
I'd like to show you the.
Perfect.
I'd like to show you the the angiogram. Ready?
Good.
Yes. Antonio.
Are you going to do a pot?
So,
You're going to do a pot?
No, we
what
don't
is
need
next?
to do
You're
pot.
going to do the IBIS, right?
Yes, IBIS.
And the effective
IBIS is
stent
very
areas.
important.
You
Yeah.
do show us. And we're going to move another room. Dr. Kang has another case, and we will be back soon, right? You have to do the IBIS, right? All right, Dr. Kang.
Okay. So, yes, as you recommended, can you hear me? Yeah, as you recommended, I changed the wire to the more stiff one with a stiff wire.
Stiff wire?
And yes, and did more aggressive
All right, great.
ballooning at the diagonal ostium. And then stent passed. Next.
And then
I put the 2.5 stent.
Balloon again.
Yes. And next, and add additional balloon for further dilation of the diagonal stent before crushing to obtain maximal opening of the side branch. Next. and then did the crushing. Next.
Balloon crush first.
Yeah, and this is the result. And next, I implanted stent next.
Just
Next.
precise placement
precise
of the prox
placement
LED, right?
At the LED.
Not, you know.
And I'm now checking the IVUS for you. There's only 5 minutes before the high pressure balloon. This is the position of the stent at the prox LED.
Oh, that's right. Great.
And here I cover the ostium. I just put the ostium, the stent at the ostium, and distally I cover the whole region. Yes, long. And the stent was placed where as I
very good transition.
Intended. Yeah.
Great. Proximal part of the stent is perfect. The precise placement, right? LED itself.
And here's the proximal LED. And I will do further dilation of the stent and do rewiring. 3.0 NC, please.
Antonio, so as you suggest, you want to do the kissing balloon inflation first, and then just the provisional stent?
Yeah.
No? All right. And then DB?
Yes, do kissing balloon inflation and then make the decision.
Make a decision. And so it's clear over side branches?
If the side branch is okay, I do kissing balloon with DCB.
DCB?
And the stent.
It's the major branch, right?
Sometimes even not to stent the major branch, but stent is the major branch is okay, and that makes the procedure a little bit more simple.
So save the stent, and right.
But the decision comes after kissing balloon.
3.5, please. 24. Deflation.
I follow Dr. Antonio during the last almost. He changed a lot.
No, but I agree with you that we need the data, but it takes time. You know,
Andrew?
It's not easy to do a prospective randomized study of TCB versus stenting.
I think it's great, Dr. Kang. So you want to do the high pressure inflation and Ivestone, right?
Yes.
All right, we want to move to
do the kissing, right?
Dr. An's case.
Yes.
Dr. An. All right. Would you show us?
I'd like to show you the IVUS, because IVUS, final IVUS is very important. If you see some suboptimal result, we have to do more.
Where is it? LED?
Yeah, this is the LED. I'd like to show you from the circumflex. Could you show us the circumflex pullback? This is a proximal portion of a circumflex.
Okay, why
Run,
not?
please. Yeah. We implanted the circumflex stent 3 hole. So stent is very expanded. Some elliptical shape because of underlying the high pressure balloon, underlying calcification. Here is just ostium of circumflex.
Hold on,
yes.
just a minute. Would you measure the standing area? Circumflex ostium?
Yeah, here is the circumflex ostium.
Ostium.
Could you show? Yes, stop
7.
here and it shows the.
Go back, stop right there.
All right,
Yeah.
here.
Measure. Yeah.
7.
If we measure around the 7, at least more than 6. Yeah, 6.0. So circumflex ostium at least 5.7. Listen to our data, 5.8. So this is to predict the circumflex restenosis, but we achieved the 6.9.
What would you expect the restenosis rate in the 10 years later, right? 7 millimeter scale.
I don't know the 10 years data, but the 5-year outcome, 5-year base rate is just 5 to 6%.
All right.
So
I agree with Antonio. You are kidding yourself if you think this is going to be patent at 5 years.
Absolutely. Absolutely. You are really kidding. The only way is not to look. Don't look.
So let's come back at 2028 and make sure that this
could you
vessel is
show
open
us
or
the
closed.
diagonal branch? So we also pull back the diagonal.
The determinant of wrist and
Run,
nose
please.
here is going to be the flow. In a trifurcation, when you place three stents, the dynamic of the flow makes prone to wrist and nose.
All right.
No matter what the lumen you achieve.
I don't want to come from B-stenosis, right? Just, repeat revascularization. Something.
But it's okay, because even if you wrist and nose, the patient may be asymptomatic because there's so much diffuse disease on the circumflex that he already has wrist stenosis now.
All right.
So I like to. I like
really,
to show you the.
All right.
Yeah, I like to show you the diagonal branch pullback. The imaging is very interesting. Here is diagonal ostium.
Diagonal ostium?
Yes, and
Almost
with left LAD.
2.5, maybe more than
Yes.
6 millimeter squares. Effective
Yeah, you
area,
can see
right?
the circumflex. Now circumflex is coming. Here is a diagonal
Big
ostium.
one, big one.
Yeah, and LAD is coming from the 9 o'clock, and circumflex coming from the 3 o'clock.
It's a great result.
Yeah, here is this left main. Left main is where stand is well opposed and very extended. So I think we don't need the additional part.
Great,
So,
Dr.
I
Han,
like
great
to-
case. It's
Yeah,
really
I like to remove the
tough.
wire.
Can we see a regular RAO projection to see
All right.
the whole circumflex?
All right. RAO projection.
RAO
please.
projection without much magnification, so we see everything.
Ready?
What do you think?
You see the distal circumflex.
I think as a clinical point of view, it's not a big deal, for a...
Look at that.
It actually looks worse now than it did.
All right.
Let's make sure we give some prasugrelor, ticagrelor here forever to facilitate this PCI.
Okay. Based on the ischemia study, it's not a big deal for the distal circumflex right now.
I think the circumflex looks worse now than it did at the start of the procedure. Something happened
It's dissected
to the
distally.
stent in the circumflex.
All right.
Go fix
Probably
it.
dissected, and it's probably going to close.
Dr. Han, really...
In 3 weeks, this is going to be closed.
3 weeks?
No, you have to fix it.
All right. A good medication should be necessary for that, right?
Yes,
Anyway, it's really good for complex PCI. If you got very good plan to how to do concern, it's not a complex in the procedure-wise, right? Okay, thank you for nice case presentation. You want to move, Dr. Kang?
Yes.
Finally, would you show us?
Oh yeah, we are doing the final kissing.
Where are you going? Where are you going?
Yeah, I did the
Still?
rewiring and did some balloon, and we'll introduce the last balloon for kissing. Can you please give
Would
me
you show us final
2.5?
angio, please?
And see- Yeah, check angio. Okay, angio is just before the final kissing.
Great. Look good.
And
It's always good, right? Yeah. All right. Well, thank
I'll show you that.
Dr. Kang, really thank you for a nice presentation. So we want to see in the
Great
later
result.
the
Let's
I'm
look at the
finding
spider that
something.
Dr. Colombo would like to look at.
Okay, so really thank you for the first session. So I would like
There you
to-
go. Antonio, this is
Thank you for joining us. We're going to start the opening here. Right?
Thank you very much. We need another big round of applause to moderators and the panelists and Dr. An in Asan Medical Center. Thank you.